Welcome to this medicine masterclass on peripheral neuropathy. Peripheral neuropathy describes disease affecting the peripheral nerves, the nerves beyond the brain and the spinal cord from the anterior horn cells. Damage to peripheral nerves may impair sensation if sensory nerves are involved, movement if the motor nerves are damaged, and gland or organ function may be affected if the autonomic nerves are damaged. Peripheral neuropathy may be acute, chronic, reversible or permanent. We classify peripheral neuropathy based on the pattern of nerves affected. If a single nerve is affected, this is described as a mononeuropathy. If several nerves are affected, usually symmetrically, this is described as a polyneuropathy. If individual non-contiguous nerves are affected, this is described as mononeuritis multiplex. An autonomic neuropathy describes a polyneuropathy affecting the autonomic nervous system. The causes for peripheral neuropathy can include diabetes. Diabetes usually affects the peripheral nervous system in a length-dependent phenomena such that a glove and stocking distribution is found. Vitamin deficiency, drugs such as alcohol, chemotherapeutics and antibiotics can also lead to peripheral neuropathy. Trauma to the nerves, radiation exposure, autoimmune processes or vasculitides can also lead to peripheral neuropathy, as can genetic predispositions. We're going to start by focusing on some of the upper limb nerves. There are 5 key nerves that we'll focus on in the upper limbs: the axillary nerve, radial, median, musculocutaneous and the ulnar nerve. The axillary nerve has important sensory and motor components. The axillary nerve provides sensation over the lower part of the deltoid, commonly referred to as sergeant's patch. The motor component is to the deltoid and teres minor. These muscles are involved in the abduction of the shoulder, as well as flexion and extension of the shoulder and external rotation. Common injuries to the axillary nerve include a fracture to the surgical neck of the humerus, and that's because the axillary nerve winds around the surgical neck of the humerus. Moreover, if there's pressure from crutches or shoulder dislocation, this can also damage the axillary nerve. So putting the sensory and motor components together, the clinical defects that you'd expect with an axillary nerve pathology is loss of sensation over sergeant's patch, weak shoulder abduction, flexion, extension, poor external rotation of the shoulder, and if you observe the muscles, in particular the deltoid and teres minor, these muscles will appear wasted. The musculocutaneous nerve also has important sensory and motor components. The musculocutaneous nerve provides sensation over the lateral forearm and provides motor innervation to the biceps, brachialis and the coracobrachialis muscle. These muscle groups are involved in the flexion of the elbow, supination of the forearm, and flexion and adduction of the arm at the glenohumeral joint. Common injuries to this nerve, which is relatively well protected, are deep stab wounds to the upper arm. Consequently, the clinical signs, you would have loss of sensation over the lateral forearm, weak elbow flexion and supination, and you would expect wasting of the muscles in the anterior compartment of the arm, and the elbow would be held in extension and pronation. The radial nerve also has key sensory and motor components. The radial nerve provides sensation to the posterior arm and forearm, as well as the lateral 2/3 dorsum of the hand and the proximal dorsal aspect of the thumb, index finger, middle finger and half of the ring finger. A specific sensory point for the radial nerve is described as the anatomical snuff box. The motor components of the radial nerve are involved predominantly in the extension of the upper limbs as well as supination of the forearm. The muscles innervated in the posterior compartment of the arm are the triceps muscle, which is involved in extension of the arm as well as adduction of the shoulder and extension of the elbow. There are a number of muscles in the posterior compartment of the forearm innervated by the radial nerve. This includes the anconeus, the supinator, the extensor carpi radialis longus and brevis, as well as the extensor carpi ulnaris. The extensors, which are involved in extending the thumb and the fingers at the metacarpophalangeal joint and the interphalangeal joints, are also innervated by the radial nerve. This includes extensor digitorum, extensor pollicis longus and brevis, extensor indicis and extensor digiti minimi. The muscles that abduct the thumb, the abductor pollicis longus, is also innervated by the radial nerve. So consequently, this nerve can be damaged due to its root by a fracture of the midshaft of the humerus or radius, pressure in the axilla from crutches, and this is sometimes referred to as a crutch palsy, or if a patient falls asleep with their arm hanging over a chair, and this is called a Saturday night palsy. Moreover, if someone sleeps in the patient's arm, this can also damage the radial nerve through compression, and that's described as a honeymoon palsy. So either a fracture of the proximal or midshaft of the humerus or radius, along with a crutch palsy due to pressure in the axilla, or somebody sleeping on the patient's arm, or the arm leaning over a chair, anything that would cause pressure in the axilla or over the proximal arm can damage and compress the radial nerve. As a result, patients will lose sensation over the posterior arm and forearm as depicted in this diagram. They will lose sensation over the dorsum part of the hand, specifically the anatomical snuff box. They would consequently have weak elbow, wrist and finger extension, absent supination, and the triceps reflex would also be affected. The tricep muscles would appear wasted, as would the muscles in the posterior compartment of the forearm, and due to the inability to extend the arm and the wrist, the patient would have a classical wrist drop. Be aware of Wartenberg syndrome. This is a specific mononeuropathy caused by entrapment of the superficial branch of the radial arm due to tight jewellery or tight watch bands, and that leads to a rather distal defect. There's no motor defect because the motor nerves have already innervated the muscles proximally, but from the wrist onwards, if the radial nerve is compressed, patients may experience numbness and tingling in the radial half of the dorsum of the hand, loss of sensation to the anatomical snuff box, as well as the dorsal aspect of the radial 3.5 digits, excluding their nail beds, which are innervated by the median nerve. And this is known as Wartenberg syndrome. To examine the radial nerve, start by inspecting the muscles innervated, in particular the posterior arm, the triceps, looking for evidence of wasting, and inspect the posture to see whether there's an apparent wrist drop. Test sensation in the anatomical snuff box. This is the first dorsal web space, as well as the posterior arm and forearm, and the sensation in the dorsal proximal index finger. The motor components can be assessed by assessing the extensors of the wrist and fingers. Ask the patient to maintain extension against resistance and see if they're able to maintain this position. The median nerve has an important role in the forearm and the hand. In the forearm, along with the ulnar nerve, the median nerve facilitates the flexor muscles in the anterior compartment of the forearm. The median nerve is also involved in facilitating pronation. In the hands, the median nerve supplies the muscles of the thenar eminence and the lateral two lumbricals. These are commonly referred to as the loaf muscles, which facilitate thumb opposition. These include the lateral two lumbricals, which are involved in the metacarpal phalangeal flexion and interphalangeal extension, the opponens pollicis, which facilitates the opposition of the thumb, the abductor pollicis brevis, which abducts the thumb, and the flexor pollicis brevis, which flexes the thumb. The median nerve has a specific area of sensory innervation. It innervates predominantly the skin of the palmar side of the thumb, index finger, as well as the middle finger, and the radial half of the ring finger and the nail beds. Damage to the median nerve can occur above the level of the elbow, at the level of the supracondylar region of the humerus. So a supracondylar fracture of the humerus would damage the median nerve. This would lead to a motor deficit as well as a sensory deficit. The motor deficit would include the loss of the pronation of the forearm, as well as weakness in flexion of the hand and the wrist. Not a complete loss of flexion due to additional support from the ulnar nerve. The patient may have a benediction sign on attempted finger flexion. And that's because the patient cannot flex their index or middle fingers, resulting in unopposed extension of these two fingers, while the ring finger and the little finger are able to flex. You would expect a sensory deficit over the lateral 3.5 digits, as well as the nail beds and the thenar eminence. The median nerve travels through the carpal tunnel. Carpal tunnel syndrome is a syndrome characterized by tingling, burning, pain, pins and needles over the area supplied by the median nerve, particularly the outer fingers, as well as the region innervated by the loaf muscles. The carpal tunnel itself is a passageway on the palmar side of the wrist that connects the forearm to the hand. It is bounded by the bones of the wrist, the flexor retinaculum. 10 structures pass through the carpal tunnel. Most of them are flexor tendons, not the muscles themselves, but the tendons. These include the 4 tendons of the flexor digitorum profundus, the 4 tendons of the flexor digitorum superficialis, the flexor pollicis longus, so 4, 4, 1, and the 10th item is the median nerve itself. Now, causes of carpal tunnel syndrome could include genetic predisposition. Pregnancy, hypothyroidism, and diabetes and rheumatoid arthritis can increase compression or damage to the carpal tunnel. The options available to treat carpal tunnel syndrome are conservative, where patients can be observed for subtle symptoms and signs. Patients can be offered splints. For more advanced disease, corticosteroid injections, or patients may require surgical division of the flexor retinaculum to relieve pressure in the carpal tunnel, leading to surgery. To examine the median nerve, start by inspecting the bulk of the muscles at the thenar eminence. Isolated wasting of the thenar eminence is suggestive of median nerve damage, either as a result of carpal tunnel syndrome. Sensation can be tested over the thenar eminence as well as the index finger. The motor activity should be tested by assessing thumb abduction against resistance, and that tests the abductor pollicis brevis. Ask the patient to turn their hand so that the palm is facing upwards and position their thumb over the midline of their palm. Advise them to keep the thumb in this position while you apply downward pressure and see if they can maintain thumb abduction. You can also test thumb apposition by asking the patient to make an OK sign and see if you can break the opposition of the thumb. 2 key tests that can facilitate the diagnosis of carpal tunnel syndrome or median nerve damage is the Tinel's test and Phalen's test. Tinel's test, tap over the medial nerve over the carpal tunnel, and if this reproduces the signs and symptoms, particularly tingling in the thumb and the radial 2.5 fingers, this suggests median nerve compression. Phalen's test is where the patient is asked to hold their wrist in maximum force flexion for a minute, and if this reproduces the signs, then this is suggestive of carpal tunnel syndrome. The ulnar nerve. The ulnar nerve also has key sensory and motor components in the upper limbs. The sensory components are particularly over the hypothenar eminence, the medial little finger, and ulnar half of the ring finger. The motor innervation of the ulnar nerve is to the 2 muscles of the anterior compartment of the forearm, the flexor carpi ulnaris, which facilitates flexion and adduction of the wrist, and the medial 2 parts of the flexor digitorum profundus, which flex the ring and the little fingers at the distal interphalangeal joints. The ulnar nerve also innervates several intrinsic muscles of the hand to facilitate fine movement. Ulnar nerve damage can occur if you have a fracture of the medial epicondyle of the humerus as the ulnar nerve passes over this structure. The clinical manifestations of ulnar nerve damage would result in wasting of the hypothenar eminence and the intrinsic muscle of the hands. The patient may have a claw hand deformity at rest and on attempted finger extension. This is because the patient is unable to extend the interphalangeal joints of their ring or little fingers, and this would result in a fixed flexion of the interphalangeal joints with a consequent hyperextension of the metacarpophalangeal joints. The clawed appearance is more pronounced if the nerve is injured distally at the wrist. A claw hand affecting all 4 fingers is less common, and that's usually due to a lesion of the brachial plexus, and that's known as Klump's palsy. As well as this, you'd expect a sensory deficit, and that loss of sensation with the ulnar nerve would be over the ulnar half of the palm, the dorsal hand, the medial 1.5 digits of the palmar and dorsal aspects of the hand. So to grossly examine this nerve, start by inspecting the hypothenar eminence for wasting. Inspect the interossei muscles and inspect for a claw hand deformity. Test sensation over the thenar eminence and the little finger, and test finger AB abduction against resistance by asking the patient to spread their fingers out and see if you can apply resistance to prevent the patient from spreading their fingers. A special test that you can use to detect ulnar nerve damage is the Froment test. The patient is asked to hold a flat object, such as a piece of paper, between their thumb and their index finger. The examiner then tries to pull this object out of the subject's hand. A normal individual with normal ulnar nerve strength would be able to maintain the grip without difficulty. A patient with ulnar nerve palsy will experience difficulty maintaining this hold and will compensate by flexing the flexor pollicis longus of the thumb. That muscle is innervated by the median nerve, and that would manifest as a pinching sign. So rather than adduction, as would occur with the correct use and action of the ulnar nerve, the patient would try to flex their flexor pollicis longus. This would be a positive Froment test indicating ulnar nerve damage. We're now going to move on to the peripheral nerves of the lower limb. Let's focus on the tibial nerve and the common peroneal nerve. A useful mnemonic is TIP and PED. TIP for the tibial nerve, which is involved in inversion of the foot and plantar flexion. Sensation is to the plantar aspect of the foot. As a consequence of tibial nerve palsy, this would result in a loss of inversion and plantar flexion of the foot, as well as loss of sensation to the plantar aspect. And usefully from the mnemonic, the patient is unable to tiptoe. PED, or common peroneal nerve, is involved in everting the foot and dorsiflexion. The common peroneal nerve provides sensation to the dorsum of the foot, all the way up the lateral leg to the knee. Consequently, common peroneal nerve palsy results in loss of eversion and dorsiflexion of the foot, loss of sensation to the dorsal aspect of the foot and the lateral leg, and this would result in a foot drop. Consequently, patients with common peroneal nerve palsy have a high stepping gait. Both of these nerves, the tibial nerve and the common peroneal nerve, arise from the bifurcation of the sciatic nerve. The sciatic nerve is the largest nerve in the body, and this ends at the upper aspect of the popliteal fossa where it divides. Consequently, you would expect, if this nerve is damaged, the combination of signs that affect the tibial nerve and the common peroneal nerve. The motor component of the sciatic nerve innervate the muscles in the posterior compartment of the thigh, the hamstring portion of the adductor magnus. Through the tibial and common peroneal nerve, the other muscles, such as the muscles of the posterior leg, the calf muscles, and the intrinsic muscles of the foot are innervated through the tibial nerve. The common peroneal nerve innervates the muscles of the anterior leg, the lateral leg, and the remaining intrinsic foot muscles. The anatomical significance of the sciatic nerve is its course. The course runs through the gluteal region, and if you divide the gluteal region into 4 quadrants, you can see that the sciatic nerve passes through the lower medial quadrant. To avoid damaging the sciatic nerve, therefore, any gluteal intramuscular injections should only be given in the upper lateral quadrant of the gluteal region, away from the sciatic nerve. Putting this together, the sciatic nerve clinical manifestations would include all of the clinical signs and symptoms resulting from tibial nerve and common peroneal nerve damage. So TIP and PED would mean you have loss of inversion of the foot as well as loss of eversion, loss of plantar flexion and loss of dorsiflexion, the inability to tiptoe resulting in foot drop, and loss of sensation over the sole of the foot as well as the dorsum of the foot and the leg laterally. Thank you for attending this medicine masterclass.